Good evening, everyone. Am I audible and visible? Please confirm. I'm turning on the live chat. I hope everyone is doing good. Everyone is preparing hard for your exams. So only about roughly about 2 weeks time is left. So I thought, why not? I'll be obviously discussing some points with you, taking your doubts which are there, like I also thought let us make it bit academic also, and let us discuss some of the important pediatric diabetes related questions also. The questions have been taken based upon what has been recently asked in the last few papers. So very similar questions have been I have taken up. So you will get an idea how questions are being asked in the recent super specialty exams, both INI as well as NEET SS, because many of these past papers are not easily available. So based upon recall, similar questions, not the same, but similar questions I have compiled, and some of the key points related to ADA 2021 guidelines also I want to discuss here. So please understand, it is not a theoretical thing. It's only a primer kind of thing where I'll be taking topics, I'll be taking your doubts, and I'll be talking about some of the academic things as well. So let us start with the session. So have a look at the question, and then I will be talking about the answer, and I will also be stressing upon the key points related to that particular thing that you need to know. Right? So let us begin. The first question is something like this. Have a look at the question. Very similar question was asked about 3 to 4 years back in super specialty exams, right? So question is strongest evidence of role of viral infection in causing type 1 diabetes in children has been found for which among the following? It's a question virtually lifted from Nelson. If you are thorough with Nelson, it should be a very easy topic for you. So what is the condition for which a strongest evidence has been there? I'm looking at the chat box. If you want to answer, you can. A, B, C, or D. What is your likely answer? Which viral infection has the strongest association for future risk of developing type 1 diabetes in children? Waiting for the answers. Even if you don't want to answer, it's absolutely fine. So, most of you are answering it correct. Yes. Excellent. The answer to this is congenital rubella syndrome. Nelson 21st edition very clearly says that almost 70% of children, 70% children who develop congenital rubella syndrome develop autoimmune antibodies or autoimmune evidence directed against beta cells. And of them, about 40% go on to develop type 1 diabetes mellitus. The interesting thing to note is that postnatal rubella or rubella in later in life or in immunocompromised patient, that does not cause type 1 diabetes. It is only congenital rubella syndrome which causes high risk of diabetes mellitus in the later life. Other than this, there are two more viruses which have been implicated. One is enterovirus and another is mumps. Please understand that latest research says that mumps probably is not implicated. Having said that, there are three viruses you should remember from exam point of view. One is congenital rubella syndrome, which has the strongest association. Second number, you will have enteroviruses, and the third number will be mumps, although mumps is the least likely one. Among the other options, congenital syphilis not implicated, measles certainly not implicated, parvovirus B19 again not implicated. So congenital rubella syndrome, whatever I said, this is what Nelson says. So please remember, please add these points and revise. So whatever, if you are attending to the session, you will also be, quickly revising some points. It doesn't harm. Other than listening to the same old things where I'll be talking about focusing on MCQs and other stuff. Motivation I don't give in super specialty mainly because you all are motivated enough. You are not young doctors or young MBBS students. You are all motivated enough. So prenatal infection with beta cell autoimmunity in 70%, type 1 diabetes 40%, and the time lag can be as high as 20 years. And there is no risk when there is a postnatal or live virus rubella immunization is used, right? So the answer to this question is A. Since I don't have a marker right now, it's not a touch screen because of technical reasons. So I'll just be telling the answer is A. Let us move to the next question. This is the question, and it's a very, very important question, and it is based upon similar question. Not same, similar question was asked three exams back. I'm not saying 3 years, three exams back in the Central Institute Super Speciality exam. So a child has been recently diagnosed with type 1 diabetes. Since these children are also prone to other autoimmune diseases, further investigations were ordered. Which among the following is the most common autoimmune association in such children? Now, you know that type 1 diabetes is an autoimmune disorder, and these children, one autoimmune disorder will predispose to other autoimmune disorders as well. So, dermatomyositis, pernicious anemia, autoimmune thyroiditis, celiac disease, all of them have been described. Which is the most common autoimmune association? That is the question. So, answer to this question, anybody wants to take a guess? I'm waiting for your answers. What is the answer to this question? What is the answer? Okay. Some are answering celiac disease, some are answering autoimmune thyroid disease. Autoimmune thyroid disease has been answered only by Dr. Shwesi. Others are answering A. I'll wait for a couple of minutes and then I'll talk about the answer. So Nand Kumar has also answered B. Everybody knows JIA, there is no association, least likely, not likely answer. Pernicious anemia, again, not very common. So the answer is between A and B. And this is what will happen with you also. Unless the accuracy is there in exam, you will get stuck up between two options, right? The answer to this question, many of you have answered it correctly. The answer is B, autoimmune thyroid disease. Let us talk some very important points related to this. So please understand. In type 1 diabetes, according to all the standard text as well as recent ADA 2021 guideline, autoimmune disorders are very common. But the most common among them is autoimmune thyroid disease. What do the guidelines say? It says it is the most common autoimmune disorder in pediatric type 1 diabetes, occurring in 17 to 30% of patients. So almost one third patients will have autoimmune thyroid disease also. Next question which can be asked to you in the exam. Suppose यही question आया, the same question was asked, and they will ask you, what is the next investigation you will do? And they will put the options as anti-TPO, TSH levels, they will put as TTGA for celiac disease, and so on. Please understand that TSH measurement, T3, T4 measurement can be faulty, and many of these patients will be subclinical. If the glycemic control is not appropriate, this is very likely that your thyroid levels, the T3, T4, TSH levels may be faulty in measurement. And that is why ADA guidelines very clearly say, please write down in any patient, any child diagnosed with type 1 diabetes, at the time of diagnosis, the child should also be evaluated for anti-TPO and anti-thyroglobulin antibodies. Please write it down. If you diagnose, suppose I am a child, I am today diagnosed with type 1 diabetes, today itself you have to get a test of anti-TPO and anti-thyroglobulin antibody. It is only after, obviously, I am diagnosed with diabetes today. I will not have a good glycemic control today. Only after good glycemic control has been achieved, then you will go in for T3, T4, TSH measurement. In that also, TSH is the usual investigation which is performed. Only when it is abnormal, you go in for T3 and T4. And again, all this is based upon the ADA recommendations, right? Regarding celiac disease, remember, it is the second most common autoimmune disorder. It is the second most common autoimmune disorder after thyroid disease. So, what do the guidelines say? Regarding celiac disease, look at what the guidelines say. They say screening of children with type 1 diabetes for celiac disease should be done by measuring IgA TTG antibodies along with serum IgA, as we do for any other patient, right? And soon after the diagnosis is made, and if the patient is IgA deficient, then you will go in for IgG based test. So screening should be done accordingly. You should repeat the screening within 2 years of diabetes diagnosis, and then again after 5 years, consider more frequent screening in those who already have a family history of celiac disease. Right. So this screening, when screening is to be done, is very important in diabetes. In diabetes itself, its complications and its associations. There is almost every alternate year a question asked from diabetes from that, right? In the end, I will summarize the areas you should be focusing on in type 1 diabetes. And the third thing, The guidelines also say that individuals, obviously with confirmed celiac disease, should be placed on a gluten-free diet, and they should also, you should get a dietitian workup. You should get a pediatric gastro opinion also taken. So these are the recommendations according to ADA, American Diabetic Association 2021. Right? Some of these are not there in Nelson, but they are very popular. And in fact, recently also there was a online symposium in which leading pediatric endocrinologists of the country also participated, where deliberations were done on type 1 diabetes. So it is something which should be on the horizon of, should be on the background mindset of the examiners, right? Let us move further. The next question. In a recently diagnosed child with type 2 diabetes, you know that type 2 diabetes is rare in children, but adolescents, yes, it can happen. And the incidence of type 2 diabetes is rising. Some people say it is because of the lifestyle changes, other people say that it was already there. It is just that it is being diagnosed more often. So with HbA1c, child is having 8.4%, so there is no good glycemic control. The child was evaluated and found to have a normal LFT and RFT. He was started on lifestyle and dietary management. What is the first line pharmacological management? See, obviously, in type 2 diabetes, you first have to start on lifestyle management, exercise, dietary control, etc. After that, you start the patient on drugs. So, what is the first line pharmacological management? This is what the question is asking. What is your answer? A, B, C, and D. I'm just waiting for your answers. A, B, C, or D. Dr. Shreyasi has answered C, metformin. Amit Anand also C, one last chance. Okay, one last chance is answering C. Beatles are answering C. So almost everybody is answering C, right? Yes, the answer to this question is C, metformin. But you need to understand that the answer will depend upon the HbA1c level in the patient, right? Why? Let us have a look at the flow chart which tells you about the management of type 2 diabetes. Let us have a look at this flow chart. So what can happen is this video which we are discussing, obviously after discussion, after this session, live session ends, it will go on the YouTube channel. It will be available within few minutes after YouTube channel. So Aram say after this, you can pause at this moment and then take a snapshot in case you want to write that flow chart in your notes. So this is what the flow chart is. So this flowchart is taken from ADA 2021, and obviously in the 22nd edition of Nelson, you will find this being mentioned there. Similar lines, it is already there in the text, but no similar flowchart is there in Nelson. So any child type 2 diabetes who's diagnosed, initially you should start lifestyle management and diabetes education, then look at HbA1c levels. If HbA1c level is less than 8.5%, you should start with metformin. Metformin, you start initially, point to note, before starting metformin, you should ensure that the patient is having a normal RFT. Renal function test should be monitored. They can ask you in exam, before starting metformin, what should you check for? Renal function test. Because in renal insufficiency, metformin can sometimes cause worsening of insufficiency. It can cause lactic acidosis in the patient. And that is why first check RFT before you start with metformin. So metformin, slowly you start and you can titrate up to 2000 mg, that is 2 grams per day as tolerated. Uh, if it is HbA1c is 8.5% or more than that, then obviously you will start with metformin. But in these patients, you will also simultaneously start the patient on basal insulin. And as because metformin is going to take some time, as glycemic control comes, you can titrate, you can taper off the insulin later on. So both insulin and metformin should be started because metformin control is going to take some time, right? And if the patient presents with, although it is less likely, more type 1 diabetes patients present with complication, but type 2 diabetes presenting with DK or any other similar complication or acidosis, you will manage that patient. You will give IV insulin till the acidosis resolves. Then subcutaneous, as for type 1 diabetes, should be given insulin as until the antibody status is known. And in all of these patients, the next step in management, if they ask, is the next step will be look for autoantibodies against pancreas. If they are positive, you will treat on the lines of type 1 diabetes. If it is negative, you will continue and start continue with metformin. If HbA1c is not being controlled, the next line of agent you will start is liraglutide. Please remember, the next agent you will start is liraglutide. Liraglutide is a GLP-1 agonist, right? GLP-1 agonist. And also remember that liraglutide, you can write, it is only recommended for use of children 10 years of age and above. Below 10 years, liraglutide should not be used. And another potential MCQ, liraglutide is contraindicated if there is a family history of medullary thyroid carcinoma. So in medullary thyroid carcinoma, it should obviously be avoided. Medullary thyroid carcinoma will occur as a part of men multiple endocrine neoplasia syndrome type 2. So if there is history of MEN2 in the family or any medullary thyroid carcinoma in the family, you should avoid liraglutide. Liraglutide is a GLP-1 agonist, but it should only be started if the child is above 10 years and metformin maximum dose has been attained or metformin is causing side effects, right? So this is the summary of what you need to remember. Hi, Abhishek. I hope everyone is, doing well. In between, also be, you have any doubts coming into your mind related to exam, where to focus, any particular thing you want to ask me, you're most welcome to do it. Before you ask me, important data related to IMR, NMR, etc., I will post in the coming days. Last 3, 4 days were very hectic for me. I was taking some classes, not for SS, but obviously for FMG and PG. I was busy in that. So I could not create time. There are some academic doubts which are there on my Telegram channel. This weekend, tomorrow and day after, I will be answering all of them. Other than that, the data also I will be compiling and I will put them up on all the social media channels, also on the group of PrepLadder also. So you will get it, the bare minimum points which you need to remember regarding the epidemiological data, right? So don't waste time in that. It's not wasting time, but you have more important things to revise. Let us continue. Using liraglutide, I've already talked. Next question. All of the following are defining characteristics of pediatric diabetic ketoacidosis except. Again, easy question. But again, it is one of the very similar question taken directly from Nelson also, PICU protocol also, it is mentioned there. So you first look at the question, then I will tell you two ways this question has been asked, or based upon recall, people disagree how this question was asked and how the answer will change. Have a look at the question and give me the answer first of all. So, all of the following are defining characteristics of pediatric DKA except. What is the answer? Blood glucose more than 200, blood pH less than 7.0, serum bicarbonate less than 15, blood beta hydroxybutyrate more than 3 millimoles per liter. It's an easy one. Yes, the answer is B. Blood pH less than 7.0. Because according to PICU protocol also, diabetic ketoacidosis should be defined where there is hyperglycemia with blood glucose obviously more than 200 milligram per deciliter in the presence of metabolic acidosis with blood pH should be less than 7.3 and serum bicarbonate less than 15 and blood beta hydroxybutyrate more than 3 millimole per liter. We look for ketonemia. If ketonemia is not possible, if you can't check for that, then only we check for ketonuria. That is an indirect marker. Now, there was another similar question where one of the option was out of this, matlab other than this. And they said the question was like people disagreed at that time. All of the following are seen in diabetic ketoacidosis except seen in diabetic ketoacidosis except, right? So option A will be seen in diabetic ketoacidosis. Option C will be seen in diabetic ketoacidosis. Option B also becomes correct because blood pH less than 7 will be seen in diabetic ketoacidosis. And option D was something else. And that was the answer in that question. So you see, by changing one word and one option, your answer becomes totally altered. And this is what examiners also will do in the exam. So when you sit in the exam, you will know the answer. But take your time and try to read what the examiner is asking. What I'm explaining here is if they are asking the defining characteristic is blood pH less than 7.3. Understood, right? But if they say blood pH less than 7 is seen in DKA, yes, it is seen. Less than 7.3 is कम ही होगा ना. Blood pH less than 7.0 can be seen in diabetic ketoacidosis. So then some other option you have to look for, and option D in that paper was totally different. It could not be recalled, but by exclusion, that was the answer, right? I hope you understand that in MCQs, you need to read the question very, very properly. Moving further, this question again. Child has been diagnosed with diabetic ketoacidosis and is being managed in an ICU. Which among the following is correct regarding the management of this child? So questions like these, you have to look at each option and rule them one by one. So they are asking which is correct, right? So we have to find the all the correct answer and other false options we have to rule out. So first option, insulin bull. You have a look at the Dr. Sachin. I can't type it right now. You can go and search anybody else you can help you out, or you can simply go to Telegram and find, or I can put it in the comments later on. So let us look at the options. Who wants to answer? Option answer is okay. Shreyasi is answering C. Siddharth Joshi C. Abhilasha Sharma C. Questions like these are actually easy. They're not difficult. The point here is you should be thorough with whatever is given. A Nelson and Pico Protocol DKA more than enough. You don't need to go into higher text than that. Okay, almost everybody has answered it correctly. See, let us go one by one. Option A is wrong. Why? Insulin bonus is never given in severe decay. In fact, AIMS PICO protocol, if you see, it is a bold में लिखा हुआ line. It is a bold line which is mentioned. We always start insulin as infusion. Nelson says कि 0.1 unit per kg के हिसाब से करते हैं, but PICO protocol says 0.05 to zero point 0.1. In practice, we start with 0.1. I hope you have managed and you know the answer, right? Option number B, insulin therapy should always precede fluid replacement in TK. Wrong. You should first start with fluid replacement. Otherwise, if you start insulin therapy first, the chances of cerebral edema will increase in the patient. Option number D, even asymptomatic hypophosphatemia needs phosphate replacement in DK. It is absolutely wrong. You want to write, you can write on the side that asymptomatic hypophosphatemia is usually, it does not require any replacement in the patient. When will you require replacement? When is phosphate supplementation needed in decay? Number one, if the patient is having serum phosphate less than 1 milligram per deciliter, right? And number two, if the patient is having severe hemolytic anemia. If the patient is having severe hemolytic anemia. Thirdly, if the patient is having any evidence of rhabdomyolysis. If the patient is having evidence of rhabdomyolysis. And lastly, if there is any hypoxemia persisting despite optimum management, or you can write unexplained hypoxemia. Unexplained hypoxemia, because low phosphate, extremely low phosphate can sometimes lead to depletion of ATP, and it can cause relative acidosis, relative decreased energy generation, which will result in hypoxemia in the patient. Again, it's a all of these studies. This is all based upon various studies which have been performed, and similar points are mentioned in Nelson also. They are mentioned in AIMS PICO protocol also, right? So, what are we left with? Option number C. Leukocytosis in DKA doesn't always indicate infection, and that is why you should send a culture. And only when there is an obvious focus or a culture comes positive, you should start antibiotic in the patient, right? So, answer to this question is C. So, absolutely right. Most of you, I'm very happy. It also means that either the competition is going to be very tough, or most of the well prepared students are attending my session. It's good. Microscopic albuminuria screening in type 1 diabetes mellitus should be started from. Very similar question asked in last NEET SS exam. It was asked in last NEET SS exam, right? So, what is your answer? At the time of diagnosis, 3 years after diagnosis, 5 years after diagnosis, 10 years after diagnosis. What is your answer? I'm waiting. I'm looking at the chat box. Okay, Siddharth Joshi is saying C. Okay, almost everybody has answered it correct. Ribhav Gupta has answered it wrongly. The answer to this question, Nelson 21st edition says ADA recommends yearly screening for individuals with type 2 diabetes mellitus starting at the time of diagnosis. So, type 2 diabetes when you diagnose it, and yearly screening for those with type 1 diabetes after 5 duration of the disease, right? And how should you be checking for? You should check the random spot urine sample for albumin to creatinine ratio, and because albumin excretion, albumin passage is erratic, so that is why you should do at least two additional samples more other than this sample on separate days. It's an easy one, but many people did get it wrong in the SS exam. And a very similar question again. Detailed ophthalmic examination in type 2 diabetes mellitus should be started from what time? So at the time of diagnosis, 3 years after diagnosis, 5 years after diagnosis, 10 years after diagnosis. What is your answer? So one last chance is saying A, Siddharth Joshi, 5 year, Abhilasha Sharma, C, 5 years. Nirav is saying B, 3 years after diagnosis. One last chance is saying C. So, what does Nelson say? Let us have a look at Nelson. Nelson says that there should be a detailed examination shortly after the diagnosis of diabetes is made in patient with type 2 diabetes. So, it will be the best answer among the option will be at the time of diagnosis. Within 3 to 5 years, not specific, either 3 or 5 in type 1 diabetes, but certainly not before the age of 10 years, and subsequently they should be repeated either annually or after every 2 years. This is what Nielsen says. So the point here is if you are seeing a pattern, you will find these are not all the questions asked in past few papers. Some of the questions are obviously self-framed. Some of the questions are inspired from similar questions, but you will find that a lot of questions are asked from diagnosis. They are asked from diabetic ketoacidosis. They are asked from complications and their screening and management. So these are the areas, if time is short, you should be focusing when you are preparing for the exam. Like the previous one, this one when we were talking about this. So the answer to this, when we were discussing about hypophosphatemia for each option, like for option number D, when you are solving such question in the in during practice, the option D you read. तो आपको पता होना चाहिए कि when should you give phosphate replacement, and you should not confuse it with potassium replacement, because if you remember the guidelines, they are very clear that phosphate replacement is not needed. Phosphate अपने आप ठीक होता है unless the conditions which I mentioned are fulfilled. On the other hand, hypokalemia, total body potassium is usually on the lower side. Hypokalemia is often present, and so potassium should be added in all patients. और hypokalemia अगर ECG changes वाला है, so you have to manage hypokalemia even before insulin therapy started. When you are giving the fluid management, you should add potassium there itself, right? So phosphate के लिए different rule है, potassium के लिए different rule है. So these are small little things you should find when you are solving, when you are practicing MCQs, and उससे related जो भी चीज है, it has a good likelihood of being repeated. So what are the takeaway points from this small brief discussion? At least you learned something new. Most of you knew the answers, which is absolutely fine, which is heartening. First thing is, yes, Rudresh, this session will be available in the YouTube immediately after it will be uploaded. So areas to focus during revision. First is diagnosis of diabetic ketoacidosis, DKA as well as diabetes itself. So दोनों का diagnosis. Then screening for complications very important. DK अब वो double हो गया. DK diabetic diabetes mellitus का diagnosis, classification and management. Then hypoglycemic reactions. All the phenomena that you read, Somogyi phenomena, Dawn's phenomena, how to distinguish between them, why they happen, where is growth hormone involved, all small little points, right? And types of insulin. It's a pharma based thing. So people often ask, sir, कौन सा drugs पूछे जाते हैं? I've told you in the previous session also that neonatal drugs are important. Uh, Antiarrhythmic agents are important. Even insulin are important. If you look at past papers, 2 years back, there were questions asked regarding the types of insulin in diabetes, their half-life, mechanism of action, names, they are important. And then latest ADA recommendations 2021. No need to read the entire segment. Simply do Google if in case you're running short on time. you will find a PDF being there. Download that PDF. उसमें जो you will obviously find कि कुछ boxes are useless. There are purple boxes given. So purple boxes जहां पर ऐसा लाइफस्टाइल मैनेजमेंट है, कितना एक्सरसाइज करना है, दैट इज नॉट नीडेड. जहां पर वो एडल्ट और यूथ की बात कर रहा है, वो यू डोंट हैव टू रीड. व्हेन दे आर टॉकिंग अबाउट चिल्ड्रन, about those, there are hardly 12 or 13 boxes. Please go through those boxes, and there are one or two flowcharts there. So it's a new thing, it's an added thing, not there in Nelson. So, but the examiners will obviously know. So just go through them once. And other than that, obviously, the usual preparation you are doing, that is good enough. Having said that, there is another clarification I want to give. A lot of people have already asked कि सर DKA डायबिटिक कीटोएसिडोसिस का जो कैटेगरीज है, माइल्ड मॉडरेट सिवियर, they are different in Nelson and different in uh, Ames Pico protocol. So which one to follow? If you see, those are different set. The references are different. These are different types of classification. Ideally, you should be reading both because we do not know which one out of these is going to be asked. While see, pH is being talked about in both classifications, right? And one is talking about CO2 level, another is talking about the venous bicarbonate levels. So, which is the one which is favored during practice in India? We follow the PICU protocol. Wala. All the Indian textbooks also give that. Nelson talks about something else. वहां पर CO2 level की बात करते हैं. So these are two different classification system. To be safe, I will remember both. But if I have to choose one, the better answer will be the PICU protocol one because throughout AIMS ho, PGI ho, all these institutes, we follow the PICU protocol wala classification. So this is um, all about the diabetes that I wanted to discuss with you. So any other doubts if you have, you get most welcome to ask. So it's a open discussion. And please subscribe to the channel, like the video. एक लाइक कर दो यार ऊपर, ऐसा ऐसा बनाओ, जस्ट लाइक इट. और कुछ नहीं है, उससे क्या होता है कि वो रीच बढ़ता है. सो एनी डाउट्स फ्रॉम योर एंड? एनी डाउट्स फ्रॉम योर एंड regarding last 2 weeks? I've just recorded another video where I have hardly 4 मिनट का 5 मिनट का वीडियो है. Topics not to be missed before you sit for exam in the last 2 weeks. So that video also will release, I think, by tomorrow. So go through that. It's no guarantee कि उसमें से कुछ आएगा, but it is based upon the past papers and the trends. So it is always helpful कि at least you are sure कि अच्छा जो सब पढ़ रहे हैं जो important है, we are going through that also. But अपना preparation you have to do yourself, right? So, Shresi is asking, could you discuss the age-wise drugs of choice for HCV? Yes, Shresi, I think you posted this query in the group also. I will answer that. I will answer that. I have to make a chart out of it. See, you may think I know everything, but I do not. I'm also a pediatrician. End of the day, nobody can know everything. So I will have to obviously, I know a few things, but those are random bits of stuff. You give me MCQ, I can solve that. But random bits of stuff, I will not answer. I will make them into a table or a tabulated list. I will put it up. As I said, till Saturday, I'm going to take as a half day for my work also, and I will be answering academic queries. It's been long time since I, read Nelson again, read guidelines again, and so I will do that. I will definitely do that. More such video, SS based MCQs. Yes, one last chance. This was one of the trial videos. As I said, ये सारे MCQs जो हैं, you would find ज़्यादा नहीं है, 7, 8 or 9 MCQs only 7, 8 MCQs we discussed today. I made all of them just yesterday only because I was traveling and I had some other commitments prior to that. But in the coming days, yes, even after SS exam is over, we will continue with the similar discussions. We'll take up one topic. So you will also know कि उस topic से आने वाला है. You'll feel better. You'll find some additional points. You will add them to your notes, right? Yes, John Biswas, types of insulin, यार ये तो you have to read yourself. Uh, you have the ultra short acting, medium acting, long acting. उसके अंदर कौन कौन से members हैं ये याद करना है. Then what is the onset of action, duration of action, and maximum duration of action. तीसरा उनका half life. Fourth, delivery system. And fifth, what is the benefit and disadvantage of each category. Hardly 5 or 6 points बनते हैं for each category, right? So it will take is even if you open Nelson, na, you will all find almost all this information in Nelson. So you just need to write it down at one place. If you want me to do it for you, I will do that. I'll do that. Arpit, one of the topics which you promised last session, yes, sir. Yeah, वो रह गए थे topic. As I said, this was a different सेशन विच दीज गाइज आस्क्ड मी टू टेक सो वो टॉपिक मैंने लिखे हुए हैं आई विल शेयर देम रिटर्न अपडेट डाल दूंगा पॉइंट तो यही है ना कि यू शुड गेट द आंसर यू शुड नो द साइनॉप्सिस ऑफ दैट टॉपिक हैविंग सेड दैट ऑब्स्ट्रक्टिव यूरोपैथी हो चुका है रीनल ट्यूबुलर एसिडोसिस बार्टर गिटलमैन सिंड्रोम graft versus host disease they are all recorded all of them are either already uploaded on channel or on the app or they will appear by today evening or tomorrow morning and other than that, HIV-1, HIV-2, summary of things not discussed in this session, diabetes, um, what else? A few other topics I can't remember right now, and I'm a bit dazed right now. So all these things, they will appear in the next 1 week or so. So nothing will be, coming after 27, 28, 29th August. Everything will come by that time. So by 26, 27, you will have everything what you asked for. I've already done most of it. Can you suggest some book for all these previous year MCQs? Remember, as I've said before, there is no real MCQ book in the market. There is, you can Google, there is one book by one of the authors, which has, I think, two or three papers of past. There is no explanation in that. So that is the only book available. Those who are targeting the next year super specialty exam or targeting INI SS later this year, can wait a bit. Unofficially, they can wait a bit. So I'm working on something. But for now, for those who are targeting, this is the only book which is there. Uh, s- as if there were lack of money, some recorded is kindly them for quick review as well as convey my message to prepare team. Okay, Tanmay. Okay. Tanmay, do one thing. If you have वो अगर कोई लिस्ट है ऐसा यू हैव अ लिस्ट कि कहाँ कहाँ पर किन वीडियोस में प्रॉब्लम है अबाउट द स्लाइड्स लेट मी नो यू कैन सेंड इट टू मी ऑन टेलीग्राम recent when to review where to review red flag signs अनस मोहम्मद रेड फ्लैग साइंस कई तरह के होते हैं रेड फ्लैग साइन ऑफ डेवलपमेंट रेड फ्लैग साइन ऑफ malnutrition रेड फ्लैग साइंस ऑफ vomiting रेड फ्लैग साइंस ऑफ diarrhea so which one are you asking for mostly red flag signs th- you can do even from Indian textbooks there is a tables which are given there yes Omendra I will ask the content team not to remove anything nothing will be removed pediatric cardio video regarding individual Porphyria part 3 हो चुका है यार. It has been done. I'll see where the video is. Porphyria part 3 I recorded many weeks back. And individual arrhythmia. Okay, individual arrhythmia, yes, I'll ask them. One last chance, as I said, missing videos, QBank, वो ना, that will happen after the SS exam is done. Unofficially, they are going to come up with some totally updated QBank. So you'll come to know about it. Neuro, it's a known fact. It's like a known fact that neuro में there are missing questions. So for now, just focus on revising whatever best you can, and we will come out with a better, pediatric neuro thing. Because neuro QBank earlier it was adult plus pediatric neuro combined, then it got split, and pediatric neuro had less questions. So that is the problem. नंद कुमार HSCT पार्ट 2 हो चुका है भाई GVHD graft versus host disease लास्ट वीक किया था रिकॉर्ड इट शुड अपीयर आइदर टुडे और टुमारो इट विल अपीयर पोर्फायरिया पार्ट 3 मैं कर चुका हूं इट विल अपीयर आइदर टुडे और टुमारो हाइपोप्रोलिफरेटिव अनीमिया मैंने नहीं किया है आई एग्री आई विल डू दैट इफ द टाइम इज लिमिटेड आई विल पुट अ 2 पेज समरी बना के मैं अपने टेलीग्राम चैनल पे डाल दूंगा so that you can read go through it. Detailed video for that will depend upon whether I get the time to do it in the next 7 days or not. Dr. Tanmay, which previous videos are getting deleted? Please let me know. I'll talk with the team. I'm right now in the office itself. I'll talk with the team. Anas Mohammed, red flag signs for development. I think it has been discussed. If it is not discussed, I'll put up a small update. It's a small thing, like it's a small 5 minute thing. System wise minor test is feasible at the app. Okay, point taken. Point taken. I'll convey to the content team. Latest CPR compression to ventilation ratio. Akula Kapil, CPR compression to ventilation ratio. Again, it is controversial. Newborn, to you know, it is 3:1. CPR compression to ratio 15 is to 2 and 30 is to 2. The problem itself is created by pulse because two different places they have mentioned different things. And even in the official publication also, there are problems related to that. So that particular query I have forwarded to one of the leading critical care specialists in our country. I'll not take the name because he's a working person right now. So I'll update. That is a point which has or which I've already promised to a lot of students. I will clarify as soon as I get proper reference on that. विपेश शाह मेक मोर वीडियोस ऑन जेनेटिक्स मोर वीडियोस तो यार मतलब जो प्रॉमिस्ड वीडियो उसके अलावा न्यू वीडियोस जो है ना दैट विल कम ऑब्वियसली आफ्टर द नीट एसएस स्टार्ट उसके बाद सो इफ यू आर टारगेटिंग द आगे वाला एग्जाम यू विल फाइंड फॉर श्योर फाइंड अबाउट इट Baki, other than this, see, a lot of things have been done. You need to understand that Nelson is huge. If we try to put a video on everything in Nelson, and you know that not everything comes from Nelson. So there will be about 1,500 hours of content. Number one, it will not be financially viable for them, for the company. Number two, it will not be financially viable for the students, and you will not be able to do everything. Having said that, yes, it's a thing in process. Super specialty exams, the pattern keeps changing. There is very limited past year papers which are available in the market. So that is why we'll try to do the maximum we can. And it is a thing in, currently in progress. So let's see. Currently, third year PGs, please arrange a structure system wise timetable test series if possible. Point taken, point taken, point taken. We are working on a lot of things. We are working on all these things and we'll take them. So, any more queries? I think we are done for this session. Time is extremely, extremely important for all of you, especially those who are targeting the 2nd September exam. So go on. If you found some useful points from that, note them down. Those who missed out on these points or want to have a look again at these points or discussions, this entire video within like 5 to 10 minutes, it will go up on the YouTube channel of PrepLadder. You can see the video again, pause it, and write down the points. Right? Telegram channel. You can simply go and search Super SS Pediatrics Resident Group Sandeep Sharma. You can use words like that and मेरा येलो कलर का ऐसा फिल्टर लगा हुआ है वो पॉपअप हो जाएगा यू विल बी एबल टू आइडेंटिफाई आई यूज्ड फिल्टर ओनली colored filter not face filter they will find you. Okay, thank you, Dr. Sreshi. It was a kind of uh, not experimental, I would say, but it was a first session of its kind. So we thought, okay, why not make it interactive also and discuss something important also. So in the in coming days, we'll plan more such sessions. So thank you very much. Thank you very much. Yes, yes, doctor. There is a what? There is no what? Sorry, WhatsApp group is not there. So thank you very much. Thank you very much. All the best. And I'll answer all the academic queries very shortly in the next 2 days. Thank you. Bye bye.